Yeah, I was talking about BRAF MEK inhibition in the adjuvant setting of melanoma. And we had a full session about different kinds of adjuvant treatment. So we started with the past and then the immunotherapy, and I was talking about BRAF MEK inhibition. So the main topic was the EADO trial, and there was an update presented on ESMO 2 weeks ago. And so that was the main results that I was presenting. Well, in the past we had nothing that was really efficient. We just had the interference. And then with ipilimumab, we had the first treatment that showed really an efficacy for patients with stage 3 melanoma, but was very toxic. And so then it was further developed to the PD-1 antibodies in the adjuvant setting. And you can say that the PD-1 antibodies, either nivolumab or pembrolizumab, reduce the relative risk to relapse about a half. So that's very, very good. But they have the risk of fatal toxicities. It's very, very low, but still it's there. And with BRAF MEK inhibition, you have a treatment that is similar efficient. So it reduces the risk to relapse about a half. And at ESMO, there was the 4-year update presented. And in this, you could see that we hope that we can cure with that about half of the patients with that treatment. Patients who are not treated with anything have a cure rate of about 37%. So there's a difference of about 17% at the moment. And with this treatment, there were no fatal toxicities, so that's very good. On the other hand, they have more adverse events that led to discontinuation of the treatment. And the main problem is fever, but I think we learned now how to really manage the fever, so it's a very good option for patients in stage 3. Well, it's a bit more expensive than the immunotherapies. I don't know how it is for all the different European countries. It's approved by the EMA, so in Europe, and in Germany we can prescribe it. So it's available for the patients and we just do it. Well, I think what is very interesting in the moment is neoadjuvant treatment. So that was the last part that I mentioned. So why wait for the surgery and then start with the adjuvant treatment? I think it's wise, and it doesn't matter if you start with immunotherapy or if you start with targeted therapy, to just start the patient, because you can see in the relapse curves from the EADO trial that half of the patients relapse already in the first year. So you have the relapses very early, and I think it makes sense to start neoadjuvant, just do the surgery then. And maybe in some patients you even don't need surgery. So for example, with this neoadjuvant trial, there was one trial published, small cohort of patients, 13 patients in the neoadjuvant setting, and 7 of them had a pathological complete response after 8 weeks. And yeah, maybe these patients don't need surgery anymore. Yeah, well, we will have an update on how many patients we can cure with the treatment, either with immunotherapy or with BRAF MEK inhibition. And of course, in the palliative setting, we are combining all of that. So we will have the same questions for the adjuvant setting. Maybe it's wise to start 8 weeks with BRAF MEK inhibition and then switch to immunotherapies. And maybe there will be something completely new, of course. So it's always we have treatments from the palliative setting that we then translate to the adjuvant setting. So I think we will have better treatments, meaning better with toxicity, and maybe even more efficient. So we hope that we don't get so many patients in the palliative setting.